Weed, marijuana ingestion really affects so many functions. I had a young kid football player, very healthy, athletic, come in for ED. And I said, do you smoke? What do you smoke? And he's like, yeah, I smoke weed every day. I'm like, you have to stop. It affects your estrogen levels. You increase estrogen, that decreases your effective testosterone. And it affects your sperm production. It affects your testosterone production. It affects your ability to achieve and maintain 100% of an erection.
Welcome back to the Unplanned Parent. I'm Dr. Angel, pediatrician and integrative health specialist, here with my vape-free, poop-cleaning, urine-catching, fart-deciphering brother, Raman. Today we have a very special guest, Dr. Lamia Gabal, board-certified urologist who comes adorned with numerous accolades, including ongoing research activity and recognition as one of Orange County's top docs. Lamia, nice to have you here today. You went to medical school at UCSD, where I also went. Our paths probably crossed there. And you did your fellowship there in urology as well. And now you have a thriving practice in Orange County. And you see men and women, which I think some people think urologists are just penis doctors. So you can tell us a little bit more about that. But we're so excited to have you here. Our audience is really interested in vaping and sperm health. And I know that means they're also interested in penile health. It's just a topic that people aren't comfortable talking about. So we're so glad to have you here and talk about it a little bit.
Yeah, real quick though, it's not just vaping. I think it's anything nicotine related, hot tub related,
Yes,
laptop related. We're all concerned about what's going on down there, but don't like to talk about it too much.
Yeah.
Yeah, exactly. And earlier with Raman, we talked about how improving his sperm health, which he did by quitting vaping, he went from borderline subfertile to very impressive. And we go Raman. So we spent a lot of time on that episode talking about that. And now we want to just talk about general penile health and see what you have to say about the use of tobacco and nicotine.
And just a side note, I love talking about penile health with my sister. There's nothing more natural than that.
Yeah, he was a little upset. He was like, "Wait, why are we having a penile specialist on?"
I wasn't upset about it. I was just like, "Oh, my favorite topic coming back. All right."
And my sister's here to witness it. Yeah.
Well,
thank you for having me. I really appreciate being on your podcast. And this is something I'm very comfortable speaking on, since I am an expert in both penises and vaginas. But yes, urologists do see men and women. A lot of people don't realize that. My path to urology was actually kind of interesting. It was just given to me as a third-year medical school rotation. I wanted plastic surgery and I wanted ENT, ear, nose, and throat. And I got plastic surgery and urology. And I was like, what the heck? Like, what does a urologist even do? This is so dumb. Like, I don't want to be playing with pee all day long. And, so I tried to give it away. I tried to trade it and no one would take it. And I'm like, fine, I'll just suck it up. And I loved it. And it was amazing. And usually people who are urologists have a pretty good sense of humor. You have to have a good sense of humor to do what we do.
A lot of down there jokes.
A lot of down there jokes. And you got to be okay with it. You got to be comfortable with talking about things like erectile function, testicular function, vaginal dryness, all those things. And a pretty good lifestyle, not a lot of emergencies. We still have our share. But as far as surgical specialties go, it's pretty good, like not a lot of emergencies. And there needed to be more women. When I finished my residency in 2001, there was only 4% of board-certified urologists were female.
Wow.
And so it's still an old boys club. I grew up in an auto parts store. My dad had a car parts store growing up. So I say kind of parts is parts. And I'm still one of the boys, I'm just one of the guys. But so I'm pretty comfortable with all that. But now we're up to almost 11%.
That's Huge leap.
So we're getting a little bit more representation. Yeah, it's great. And because women end up with urological issues as well, you know?
You're comfortable with it. Are your male patients as comfortable as you are, or do you get a lot of awkwardness?
Well, and by the time they come to see me, they obviously know they're seeing a female. There are many men who prefer a female urologist because if someone's going to be messing with your junk, you know, they might feel more comfortable that it's a woman. I have smaller fingers than the
Right here?
guys. There you go. See, you prefer a woman. So when it comes time to a rectal exam, like, you know, smaller fingers are key. So another reason why you might prefer having a female urologist. And I think most people just want a good doctor, you know. So sometimes there's awkwardness, sometimes there's spontaneous erections, sometimes there's, you know, things, you know, that happen. I've got really good stories. But
Please share.
Do you take that as a compliment or like a wow, you're a weirdo? Like, do you actually even need to be here right now? Or are you here because you want a woman to grab your junk?
yeah, it is interesting if a patient comes in for erectile dysfunction and they have a full erection when you're examining them.
Yeah.
So
The irony.
that is like, well, your machinery's working, so let's talk about maybe some other reasons why this could be happening.
Do you recommend them like having sex in a hospital setting, maybe?
Yeah, exactly. Have your partner put on this coat.
Yeah, yes.
So-
There we go.
Wait, I want to know how you told your parents, and are you that comfortable with your parents that they talk about, like, you know,
She's
penises?
a doctor. What are you talking about? Like,
No, but how do you tell your parents you're going to be a doctor of penises and vaginas? Like, that's different.
That's a good question, Angel, Dr. Angel, because like when I first told my family, my sister, who she's since passed away, but she was like, "Oh, you're going into urology to meet men?" And I'm like, "No, they're going to be
ooh.
old and impotent." Like, no, those aren't the ones that I want to meet. That's not what we're trying to meet here. No. So yeah, and so my parents came here from Egypt when I was 2, and it was for better opportunities, you know, for their children, right? So a lot of pressure. You're going to be a doctor. You're going to be a lawyer. All kinds of pressure. So to your point, Raman, they just wanted someone to be a doctor, you know. And so when I explained to them, you know, it's a surgical specialty. It's this, is that. I grew up actually very comfortable. My dad was very open about sex and stuff. And, you know, sex is great, but you can't have it until you're married. And, you know, like, you can be married, but you only have to marry a Muslim. And there's a lot around all of that, you know, so, and he's also since passed away, but very open about things. And so that was helpful. My dad would say, he would say, so when I was growing up, the girls would say they want 12 inches. And I would say, I'm not folding mine in half for anyone. So, so that was like the environment in which I grew up.
He sounds like a cool dude.
Yeah,
He
I don't
was.
think I would have been able to be that comfortable telling my parents if I were going into
Yeah.
urology. I didn't even tell my parents that I was pregnant. I made my husband do it. I said, Tim, you have to tell them, because if they hear from me that I'm pregnant, then they're gonna know that I had sex.
I know. That's hilarious.
That's why I had a baby through IVF.
I was just thinking the
You
perfect.
guys are
You
not
didn't-
allowed.
Didn't want to break that whole, you know, celibacy thing. That vow
Yeah.
I have with my Indian parents.
So, Lamia, let's talk a little bit about tobacco and nicotine products and how they affect the genitourinary system, and what does that look like in your practice?
Yeah. So a lot of people really don't realize how much smoking, vaping, you know, any kind of tobacco and nicotine can affect the urinary tract and the reproductive tract. And I routinely get young men in my practice who come in for erectile dysfunction, libido issues, you know, these kinds of things. And my first question is, how much do you smoke? What do you smoke? Because, you know, a lot of people just don't realize. They think, oh, this is fine. Everyone does it. It doesn't affect anything. And it really affects so many things in the urinary tract. So we know that smoking, nicotine, cigarettes, mostly causes really bad things in the urinary tract later in life, like prostate cancer, kidney cancer, bladder cancer. Smoking is the number one risk factor for bladder cancer. But, so that's the biggest thing that we deal with as urologists in terms of smoking with long-term effects. We also know that smoking also affects the vasculature, right? It affects the blood supply and the blood supply everywhere. So when a man comes in at any age and says they're having trouble achieving or maintaining 100% of an erection, getting a smoking history, finding out what they smoke, how much they smoke, if ever, is really important because it affects the blood supply to every single organ. And when you decrease blood supply, things just don't work. And we know there's a super high association with erectile dysfunction, I should say, and cardiac dysfunction. And so in my patients who maybe come in and see me because, their penis is probably the most important organ, which, I understand that. So they might not have a primary care doctor. They don't have a cardiologist. And I make sure that we do some sort of screening for their heart health as well, because there is a high association with tobacco use, erectile function, and cardiac function as well.
So can you give me like some numbers? Like how much is it? Like a little bit of an increased risk if you're smoking or vaping to have erectile dysfunction, or like what is that overlap there between erectile dysfunction and smoking and vaping?
And just to add in there too, is it the nicotine itself, or is it the smoking part of the nicotine? And when you said a lot of young men, like what age group are we talking about?
Well, okay, when you talk about age groups and how much erectile dysfunction we see, really about 20% of 20-year-olds have some form of ED. It's a high number. And as you get older, it's a higher percentage. So by the time you get to 60, about 60% of 60-year-olds have erectile dysfunction. Super common. And I'm so glad that we're able to talk more about it because, for so long it was taboo to talk about the penis, to talk about the vagina, to talk about erectile function. I think Viagra and meds like it have really brought it out more towards the forefront because pharmaceutical companies have a great way of creating conversations around these things to make us want these things. But it's good. I mean, that's a good byproduct of their marketing, that now people are more comfortable talking about taking a little blue pill or, needing the little blue pill. And it's just, it's not as taboo to talk about those things. So, but the smoking issue, I mean, it could be as high as a 50% increase in erectile dysfunction. I'm always surprised if I see a man who still smokes and does not have ED, and especially an older man, because it happens. And some of it comes down to genetics as well. But for the most part, it's completely affecting the vasculature, the blood supply, and it's going to affect the ability to achieve and maintain 100% of an erection. In my practice, I do a lot of regenerative medicine. We use platelet-rich plasma. We also use some exosomes and stem cells and those kinds of things to try and regenerate nerve endings, collagen, elastin, blood vessels, in order to regenerate function, reverse the clock, if you will.
Don't tell me you inject the PRP into the penis, right?
I won't tell you, but that is what we do.
Oh, wow.
So,
holy moly.
It's not as bad as you would think. It's a very skinny, tiny little needle. We never inject the head of the penis. It's just the shaft. It's just on the side. And sorry, it doesn't hurt me one bit. It's making you cringe, I know. But and then we use topical cream. It's really not as bad as you would think. And nope, listen, I get a lot of stuff done on my face. No pain, no gain. I mean, it's just we need to do all this regenerative stuff. Some of it hurts, but it's worth it. And again, one of the first questions I'll ask these guys who come in, by the way, we also do this for penile enhancement. We can get extra length and girth by using PRP and stretching and vacuum devices and that. But I will not do it on someone who smokes or vapes because I will tell them that they are wasting their money. It's just, the cells don't regenerate. We're not getting the blood flow. And to your earlier question, Raman, some of it is the nicotine itself, because it causes vasoconstriction. It causes those blood vessels to constrict even more and decrease blood flow. So the delivery of oxygen and the healing factors is affected. But it also, the smoke itself impedes, blocks some of the effects that we're trying to achieve.
So what if it's like nicotine from like what baseball players are doing, like snuff or pouches or Zins that are really common these days?
It's probably better in terms of they're not having the smoke inhalation component, but the nicotine itself still has physiologic changes. It still causes changes in blood pressure. It causes, blood supply issues. So really, no nicotine is best. Again, I have patients who come in and they say, well, I'm trying to cut down and now I'm using a patch. Well, that's better, than smoking and having increased doses, because less is better, but none is best, really. And a lot of young men don't realize. The other part of this is marijuana. And so marijuana ingestion really affects so many functions. And a lot of men don't realize. Like, I had a young kid football player, very healthy, athletic, come in for ED. And I said, do you smoke? What do you smoke? And he's like, yeah, I smoke weed every day. I'm like, you have to stop. It affects your estrogen levels. You increase estrogen, that decreases your effective testosterone, and it affects your sperm production. It affects your testosterone production. It affects your ability to achieve and maintain 100% of an erection.
And once again, that's the THC and the smoke combined, or both individually can do the same?
Individually and combined. It's just the THC has a hormonal effect. It absolutely affects the testicular production of testosterone and also increases fat production of estrogen, because we all have fat cells. We all have an enzyme in our fat that converts testosterone to estrogen, to estradiol. And so we find higher estrogen levels in chronic marijuana smokers, chronic THC intake. That's why they develop breast enlargement. There's several things that come along with chronic marijuana use. And one of the biggest things is infertility, erectile function, higher estrogen levels, just all of it that people don't realize that it affects.
Yeah, it's amazing what we men all partake in. With the chances of losing so much ability down there.
It just doesn't get talked about.
Yeah. And I will say, even as a pediatrician, you wouldn't expect me to see a lot of erectile dysfunction, but I have seen older teen boys, young men come in with this complaint, and I've only seen it in young men who smoke marijuana, and one instance where it was vaping, but it's mostly been marijuana use.
Smoking. Mm-hmm.
So, Dr. Angel, are the guys who come in who are using marijuana, are they really chill about their erectile dysfunction?
I'm sure they're very anxious about it, just to be honest. You would think it would chill them out, but
yeah. So there's cardiovascular causes of erectile dysfunction. There's smoke inhalation, use of nicotine, tobacco, marijuana. What about other causes of erectile dysfunction? What else are you seeing?
When I did my residency, I finished back in 2001, back in the dark ages. We would tell men, because we didn't have a lot of good treatments for ED, and we would say, oh, it's all in your head, go home, have a glass of wine. But But there's a little truth to that because this is the biggest sexual organ that we have, and I have this discussion every day with my patients that if this isn't okay, what's going on down there is not going to be okay. So anxiety can play a role, if we're anxious about anything, especially performance issues, that's like a vicious cycle, right? So if someone has one mishap in the bedroom, it doesn't necessarily mean that there will be more to come, no pun intended. But sorry, sorry, you can cut that out. And
No, that's okay. We have a mature audience.
Except for me.
except for, but if it causes more anxiety, well then guess what? Now you're putting out epinephrine, you're putting out catecholamines, you're so anxious, which causes more vasoconstriction, and it causes your penis not to work. And so it does become this vicious cycle. So anxiety can be a huge component for erectile dysfunction. Medications can be a big component. I had a young man who came to me who was on Finasteride, which people will take for hair growth. It's also known as Proscar. We give 5 milligrams for prostate shrinkage. We give 1 milligram to maintain hair growth or to increase hair growth. And I look, again, it's important to look at the medications and whatever substances they're ingesting. And I said, it seems to be correlated with when you started the finasteride, because it does cause some hormonal changes kind of at the tissue level, mostly at the prostate, but he stopped his finasteride and his erections came back. So, medications can, and especially blood pressure medications.
but now he's bald, so no women are into him.
Bald and happy. I mean,
I'm just kidding for all you
some men
bald
look
men
good
out there.
bald. Yes,
I know.
some
I
men
was
look
just
good
joking.
bald.
I'm just kidding around.
Just because you have as much hair as I do, Raman, I know. We're both blessed to have this amount of hair.
What about weight? Does weight, obesity
Yes.
play a role in erectile dysfunction? And can you talk about that?
And also penile size. So, again, we see a lot of different complaints for men as they age, or even young men, when they come in. But we know that obesity plays a huge factor in erectile function and dysfunction because, again, having more fat cells, we get more conversion of testosterone to estradiol. So now the estrogen is fighting whatever testosterone is there. We also see metabolic syndrome with obesity. So diabetes, hypertension, all these other issues that happen that also then affect the penis. And so obesity is bad. There is something called Ozempic penis. I don't know if you guys have heard of that.
No.
Ozempic penis?
It's on Reddit, and it's a big thing.
It doesn't work anymore?
No, it's better than that. It actually looks bigger for the men who are taking Ozempic because what happens when they're obese is that the fat kind of engulfs. I'm not joking. That's what happens. And so I have had patients who come in and they're like, my penis is shrunken. And then if you pull back their penis, I'm like, look, it's there. It's still there.
Wow. So it's like the ratio of belly size to penis.
Well, it kind of engulfs it, yeah. And so when they lose weight, like they can see more of the penis. Exactly, more is like unearthed from the tissue around it.
Well, so that happens a lot in infants, and I didn't realize that it would happen with grown-ups too. And parents are really worried when all of a sudden their baby boy's penis has kind of disappeared, and I have to put, I show them how it can reemerge if you just put the pressure in the right places and it pops out, but it really gets kind of
engulfed.
Engulfed. That's the right word. Yeah. Engulfed by all the surrounding tissue.
Sorry. And along with the obesity, obviously, diet and exercise are, kind of coexist with that, right?
Yeah, I mean, that's always good. I always tell my patients, anything that's heart healthy is going to be penis healthy. So, eating antioxidants, exercising, doing cardiovascular work, trying to stay away from things that are more pro-inflammatory. The body doesn't like total body inflammation. Total body inflammation is bad because that increases the risk for cardiovascular disease and cancers and those kinds of things. Now, That being said, sometimes we create localized inflammation in order to regenerate tissue. So if I add shockwave therapy, which is not painful, it's sound wave therapy, to the PRP, that actually helps to improve erectile function better than either one on its own, because we're creating a little bit of localized inflammation, and now the body likes that inflammation in order to heal, have something to stick to when we're injecting that PRP into the penis, Raman.
So with like shockwave therapy and, all these ED medications, are you finding more and more dudes out there are like, hey, I can let myself go because modern medicine will save me?
Let myself go. I don't think I'm seeing more of that. If anything, to be honest, I'm seeing more men who are paying more attention to it and seeing us, because maybe what they got on the internet isn't working. So, I do see a lot more men who are coming in now, like, I got hims or hers. I'm like, what did you get? I don't know. It just says this. And I'm like, this is so bad. You don't even know what you're taking.
Yeah.
So, but it's brought it to their attention. And then they do come in then, because it's way too easy to get that stuff online now. And so, but I think again, it's at least bringing the conversation more to the forefront and making people more confident and more comfortable in speaking about all these things, penile function, penile size, and, vaginal function, all these things that are really important as we get older. And I'm glad that more people are talking about it.
So when it comes to treatment options for erectile dysfunction, so first of all, you're not even going to offer a lot of these interventions. It sounds like you're not even going to offer to people who are smoking anything, nicotine or marijuana, right? You might just offer them this. What would you offer those people? First of all, you would tell them to try to quit smoking.
100%. That's always what I recommend first off. And they'll see improvement, just with that. There are some nitric oxide supplements that you could take. There's a brand called Affirm that we normally recommend, AFFIRM. And again, yes, pun intended. And so that is, it helps.
Oh gosh, that took me a minute.
Affirm. And so that one, just nitric oxide is the hormone, the little neurotransmitter that's used at the level of the blood vessels to open up blood vessels to get more blood flow. And it helps for lungs, it helps for penis, it helps for heart. So if you take a nitric oxide supplement, something that increases, it boosts your nitric oxide, that alone can help. And usually it's a supplement, not a prescription medication. Of course, like you said earlier, Raman, diet, exercise, that kind of stuff. But then if that doesn't work, the pills can work. It depends on how far along they are in their disease process. It's always easier to treat something, to reverse something when it's earlier in the disease process, as opposed to, I will say I've had 80-year-old men come to my office sometimes. Now they have a 50-year-old girlfriend and they're like, I haven't had an erection in 20 years. Can you fix me now? And I will literally say, I'm sorry, I can't raise the dead. But I know it's kind of sad, but if
Is that a pun too somewhere?
I know somewhere in there, I can't raise it. But if we would have started earlier in the process, like the sooner you get help with, especially the regenerative stuff, the better, because the more far gone the disease process, it's a lot more difficult to treat. Viagra won't work as well. The regenerative treatments won't work as well. And so we really want them to come earlier in the process.
So people like myself who have no ED issues and are super healthy, but want to make sure...
Just throwing that out there for everyone to know.
Yeah, just throwing that out there. And just want to make sure that continues into old age.
Yes.
Is there anything proactively we should be doing that could be like administered from someone like you, as opposed to just diet and exercise? And
yeah, I mean, the usual things like we talked about, diet, exercise, again, anything that's heart healthy is going to maintain penile health. But the penis and the vagina, for that for that point is they're both use it or lose it organs. And so if you stop having erections, things will shrink, things will stop working, the tissue will atrophy, just like if you stop using your leg or your arm. And so continued use, more having erections more often, the doctor's orders, helps you actually to maintain your penile health as you get older. And also vaginal health. I see young women, old women, but if we're not having sex, things shrink up, things literally shrivel up. So we want to keep having sex or masturbating. I mean, there should be more conversation around that. It's very healthy. People need to be doing that as a release, and it also gets more blood flow. And so, there's things that can help you to maintain your penile and sperm health, even if you don't have a partner.
So we've been talking a lot about the penis, and you've been mentioning vaginas here and there.
Yes,
Is that
yes.
also part of your kind of specialty? I don't know exactly what a urologist does, but
So urologists are surgical specialists of the genitourinary tract. So we treat things like bladder cancer, kidney cancer, prostate cancer. We also treat kidney stones, urinary tract infections. My subspecialty is female pelvic medicine and reconstructive surgery. And so I have extra expertise in things like prolapse, which happens after babies. Having babies is not natural. It's like it tears apart your pelvic floor.
I'm right there with you after witnessing what happened.
How anyone survives this. I mean, and that's the thing. In third world countries, a lot of people don't. People don't realize that. We're so lucky to have the medical system that we have that surrounds, all of this.
It looked like a Dateline episode after Ashley gave birth. I was like, holy, yeah, it's just crazy.
Holy moly. I know. So it's, so it tears apart the female pelvis, the pelvic floor. And so women after childbirth end up with leaking urine when they cough, laugh, and sneeze, the bladder dropping, the rectum dropping, the uterus dropping. You can have leakage of stools.
That could be a rap song right there, by the way.
Drop, drop, drop.
First the bladder, then the rectum.
And so, all about childbirth. So it is, so that's my subspecialties, but urologists treat both men and women. And a lot of people think that we're just gynecologists for men, but that's not true. And I think that's why traditionally it was more a male, heavy specialty, but now a lot more women are going into it. And because some women prefer to speak with a woman about these kind of more personal issues, especially when it comes to urinary function, sexual function, if they want to talk about their vaginas, hormones play into this, a big part of this too. And there's a lot of discussion now about the perimenopause and menopause and how it affects our libido and our vaginas, and all of that. So that's great that's coming to the forefront now as well. And there's a lot more conversation around that.
So is there a female version of ED out there? I'm assuming there has to be, right?
Female sexual dysfunction is huge and unfortunately is a lot more complicated than male sexual dysfunction because there's so many different pieces to it that could be a dysfunction, whereas men, it could be ejaculatory dysfunction. That's more difficult to treat actually than erectile dysfunction. We still don't have a lot of good treatments for that. We have better treatments for premature ejaculation than we do for delayed ejaculation or anejaculation. There are some men who can't ejaculate. Usually it's a back issue, a spine issue, some sensory issue. But that's harder to treat. Erectile dysfunction, we now have great treatments. I don't think I finished on that either about the erectile dysfunction treatments. The last resort for erectile dysfunction would be, there are some men who give themselves an injection every time before having sex. There's a medication called Trimix that then increases blood flow. And that works really well, but you can imagine it's not very spontaneous. It sounds like you've never heard of this.
Just hold on, honey.
Exactly. So the spontaneity gets out of it, but they are able to have sex. And then also there's implants that can be placed into the penis under anesthesia, of course, where it's a pump or what we call a malleable device where it just makes the penis erect for intercourse. And a lot of people don't know you actually don't need an erection in order to have an orgasm, in order to ejaculate. So I have men who are not able to have an erection, but they can masturbate and still, come to orgasm, and that's okay. I mean, you only need really. I know you're like mind blown right now.
No, yeah. I mean, I'm just thinking at some point, are you just like, hey, patient, whatever, X, God doesn't want you to have sex or enjoy this part of your life. Go do something else.
No, I mean, it's a conversation that I have on multiple times, probably with the patient, and they feel comfortable talking to me. And I obviously have no trouble asking about these things, and ask if they masturbate, especially if they say they get zero erections or those kinds of things, because it's natural. It's a release. It's something that people should be doing to keep the machinery working. But in terms of female sexual dysfunction, it could be libido issues. It could be trouble with orgasmic function. It could be trouble with vaginal dryness and lubrication. It could be trouble with just the initial phases of arousal. So there's all these different pieces to female sexual dysfunction that really it's just more difficult to sort of feather out where that's coming from. And then unfortunately the treatments aren't as good at this point yet either.
I wanted to go back. Thank you for that. I wanted to go back to Raman's point about God doesn't want you to enjoy this part of your life.
Yes,
I would
yes.
disagree with that on so many terms.
It was a joke.
I know it was a joke, but I just in case any of our audience members out there are offended, I just want to just say, I think if you look at it like, my daughter has asthma, and people could say, well, oh, she just shouldn't be running and playing in the grass because that triggers her asthma. But that kind of sucks for her. So if there are medications out there, treatments out there that help her go out and enjoy nature, because even though she's allergic to it, I mean, right? Like, she should be able to partake in those activities. And if that means taking the medications to do so, that's okay. So I think just to destigmatize sexuality a little bit, also, I think we can look at it in through that lens as well.
Yeah, and I have that discussion. And so, I'll always ask about their sexual activity. Are you sexually active? Some people will apologize and they'll be very apologetic and say, no, like my partner is this, or I'm like, don't apologize. Like, if it's not important to you or your partner, that's okay. But if it's important, if one or both of you think that there's an issue, then there's an issue, that might need to be addressed. But I have many couples who haven't had sex in years and they're okay with that. And I have many couples who haven't had sex in like 2 days and they're not okay with that. So it's like, it's a spectrum. And then I tell them also, like, it depends on how far you want to go with this, because I mean, I don't know that I would say, Raman, like, we don't want you to be having sex, so we're not going to treat that. I know you were joking. But me or God. And so, but it just depends on how far you want to go, because with a man, especially if they end up going to surgery and having a pump placed, we can get them having an erection, we can get it working. But there are some men who will stop with, the earlier treatments. No, I don't want to go that far, or some women, we might try some of the hormonal stuff. We might do a laser for the vagina for atrophy, for thinning, to help with lubrication and stuff. And, but they don't want to do other, maybe more surgical options, So it just really is a big discussion that needs to be happening.
We're veering into women's health. So can you just maybe make a plug for topical estrogen and why that helps with vaginal atrophy and also for UTI prevention?
Yes, so it's so important. In the early 2000s, again, the dark ages, when I finished my residency, there was all this bad data. The Women's Health Initiative back then did women such a disservice. I mean, it was the first time that any study they had like a big press conference in the middle of the study, and they stopped the study and they said, look, hormones are bad. Everyone needs to get off of hormones. And unfortunately, there's so many doctors that still believe that. Like, they don't continually learn. If there's one piece of advice I could give you is find a doctor who continues to learn, because, so much changes about medicine. And when I finished back then, we thought it was dogma. You can't cure a virus. And now we're curing every virus. And so, same thing with hormones. Once they really looked at the data and feathered it out, and yes, for a small subset of people, for a very small subset of women, estrogen may be harmful, but everything in life is risks and benefits. Driving may be harmful. Getting on an airplane may be harmful. And so you really have to decide for yourself and risks versus benefits. So especially for vaginal health, as we get older, when we lose estrogen in the vagina, we get dryness, burning, itching, trouble with lubrication, pain with sex. We also see urinary tract infections, leakage of urine, overactive bladder because of the thinning of the vaginal tissues and the lack of estrogen. The tissues just become, more thinned out. So again, starting regenerative processes earlier are so much better than starting later. That was one other thing that came out of the Women's Health Initiative, where they said people took out of it, you can only be on estrogen for 10 years if you're going to do it. Well, really what that came from was that after 10 years, if you started estrogen after 10 years, there was no benefit for heart disease, for prevention of heart disease. Well, of course there wasn't, because you had 10 years without estrogen. And so, when you really look at the data, the earlier you start, the better. And so I'm going to be on estrogen and testosterone the rest of my life because I want to be sexually active. I want to be vibrant. It's good for brain health and heart health and vaginal health, all of that. So, we do pellets. We do the bioidentical hormone pellets for the hormone replacement in our practice. But I prescribe a lot of vaginal estrogen because when we do the systemic replacement, whether it's a patch or a pill or a pellet, it doesn't get to the vagina very well. And when we do the vaginal replacement, it really doesn't get systemic. So there's many women who need both. And the vaginal replacement of estrogen helps so much for all of those symptoms that I had mentioned. We also have a laser that helps for that. It's called the Mona Lisa. It's a radiofrequency laser that helps also to regenerate younger, healthier tissue. So,
And why is it called the Mona Lisa?
That's a great question. So the man who invented it said, now you know why the Mona Lisa's smiling.
Oh, that's pretty good.
Isn't that clever? I don't know.
Yeah.
He named it that because the Mona Lisa has that little smirk.
Yeah.
So he
Yeah.
said, now you know why she's smiling.
Yeah, no, I just think that's so important because just preventing UTIs it can be life-saving for many women, and for people who are still kind of slow adopters of hormone replacement therapy. I think what you're saying also is that you mentioned this briefly, that vaginal estrogen is not really systemically absorbed, but it will do the job locally, and
Exactly.
so that it can help prevent UTIs and help with vaginal atrophy. So, but I, just for anyone out there who's wondering, I too am on hormone replacement therapy and plan to be on it for a long time. And you mentioned many of the benefits, and one other one I just want to add is bone health, and I think that's another reason to think about systemic hormone replacement therapy.
Wait, so am I the only one not on hormone replacement therapy, and should I jump on
I
it?
mean, testosterone pellets can help. But let me mention this, actually. For sperm production, any kind of external testosterone replacement is going to shut down your body's own testosterone production. Okay. Your testicles need the endogenous. Your testicles need your internal testosterone production in order to produce sperm. So your testicles do not see the exogenous, the external testosterone. And so I have actually had young men who come in, maybe they're bodybuilders, and they do testosterone injections, and your testicles shrink as well because
Which are steroids or no?
Yes, yes.
Okay.
So testosterone is a steroid, and anabolic steroids would be like much higher doses and sometimes different chemical compound. But yes, testosterone is a steroid. And so when they do the injections, it shuts down their testicular production of testosterone. Testicles then shrink because they're like, hey, I don't have to produce testosterone anymore. And when you don't produce testosterone, you don't produce sperm. So their semen analysis will show zero sperm. And once you come up, again, a very important reason to ask about ingestions. A lot of men will forget about that because it's not something they do every day. And so they, once they stop that, within a few months, the sperm production can recover. It usually does, but it takes 72 days for the life cycle of a sperm. So it takes at least like 2 to 3 months to see any changes. Like what happens today will affect what happens 2 to 3 months from now, what you see in the ejaculate, what you see in the semen. And what a lot of people don't know is the sperm is only about 2% of the volume that comes out of your ejaculate. That about 30% comes from the prostate and about 70% comes from the structure that lives on top of the prostate. They're called the seminal vesicles, like a heart shape on top of the prostate.
So as a 46-year-old, if I'm feeling good and feeling healthy and feeling like everything's intact and working, just ride it out.
You should be fine without the need. There is menopause, right? Andropause, which does happen as men get older, their testosterone levels naturally decline. And so when you see the normal range for testosterone levels for men, it's somewhere around like 280 to 1250. Well, if I see a guy that comes in his 40s and it's like 300 and he's telling me, I'm tired, I don't have a sex drive, I have, energy level, all these things, I'm going to give him testosterone. And where someone else might say, oh, no, you're normal. But that's not normal. It's not normal for you. And in fact, when we replace testosterone, we want it optimized. I want it greater than 950. And that's where really our male patients will feel the benefit in terms of energy level, sex drive, muscle mass to fat ratio, sense of well-being. Like all of those things are improved if it's optimized. You need a minimum amount of testosterone to have an erection, about 180, 200 range. If I see a man who's profoundly low, and again, on young men, that's another thing, Angel, that we'll check on a young guy who comes in complaining of ED. I'll definitely do a hormone panel. If they have profoundly low testosterone, then giving them more T might actually help with their erections. But if they're already above that threshold, more testosterone is not going to be helpful in terms of erections. It'll help with all the other stuff, but not for the ED.
Wow. So this is very nuanced, and this is why you need to see a urologist if you're having these kinds of difficulties. And it's really, I think, just a reminder that while there's a lot of information out there, specialists, doctors have just this deep knowledge, and go find your local urologist if you're having any of these concerns.
All right, doctor. Let's move on to our medical breakdown.
All right. So, Dr. Gabal, thank you for all of that. So let's just do a quick review. Tobacco, nicotine, and marijuana products all affect penile health in addition to sperm health, as we mentioned in a previous episode. That's not just the nicotine tobacco, but also all the chemicals that are in the cigarettes or the chemicals that are in the vape products. All of those affect the vascular lining, all of those chemicals. Can you just quickly review, Dr. Gabal, can you review how that affects the reproductive health of men?
Yes. So all of those, the nicotine, the smoke, the chemicals that we don't even know are in some of these products can affect the reproductive and penile health by affecting the lining of the blood vessels, as you had mentioned, and then decreasing nitric oxide production and causing the blood vessels to constrict, what we call vasoconstriction, and affecting blood flow as a whole.
Great. So let me ask you, nitric oxide, I know that there are certain foods that can increase nitrous oxide production and are even associated with lowering blood pressure, for example, beets. Are there any studies that you know of that are looking at erectile function?
Unfortunately, I don't know about any studies for that. No, I know that beets increase your risk for kidney stones because
They
they're very
do?
high in oxalates.
Wow.
Look at that. So,
And they make your poop look red and freak
yes,
you
they're
out.
good for one thing and not good for another thing.
There's
Yeah.
something called beta-turia, which patients think they're seeing blood in the urine. It's like, did you have beets?
That runs in my family. Mhm.
Yeah, it's a genetic thing too. It's how you process that, whatever that xanthide is, I think the color.
Yeah, my daughter has it, my youngest has it, and I have it too. So,
And so does your brother.
do you have it?
Well, I mean, when I eat beets, my poop is crazy red?
Oh, but your pee.
I don't know if my pee is red, but my poop is definitely like, uh-oh.
It's okay.
Okay, yeah. I think the poop is more common, but the pee is a little less common. Okay. All right. And then one other thing I wanted to just mention is that teens are also exposing all of their reproductive organs if they are vaping or smoking marijuana. They are also exposing their reproductive organs to all the chemicals there. And it's right around the same time. So teens generally start smoking or vaping around age 13. And that's also around the same time that sperm production starts, the puberties get kind of coming into full effect. So it's, for parents out there, have that conversation with your kids. It doesn't have to be super accusatory, but more just kind of a getting to know what's going on with their friend group. Do they have friends that are smoking marijuana? Do they have friends that are vaping? And let your teens know all the various thoughts that you have on smoking and vaping and what you learned today so that they can put that away in the back of their mind next time they're offered a cigarette or a vape or a joint.
Very important point. They don't think about that.
Shall we move on to, is this normal? The doctor at the IVF clinic said, only 4% of my sperm looked normal. Doctors, is this normal?
Yeah. So actually, yes, that's normal. And I think, Raman, before you quit vaping, only 2% of your sperm looked normal.
Doubled.
So you were, yes, exactly. You had, remember that funny looking sperm you had. But then after you quit vaping, we waited that 3 months, as Dr. Gabal mentioned. It's that 72-day cycle. So you waited 3 months and gave another sample. And now you had 11% of good-looking sperm, which is great because actually 4% is the norm. So the average man has only 4% of normal-looking sperm, which I think is just really interesting. And so we did have a listener question about, well, what's the big deal? What happens if you don't have enough good-looking sperm? What is the problem? Why do we care about what the sperm looks like? And it's because what the sperm looks like actually often reflects what's happening inside. And also the function is affected. So if you have, maybe, Dr. Gabal, you can talk more to this, but if the sperm has a pinhead or a big head or two heads, then it's going to have more difficulty penetrating the egg. But it also could be reflective of the DNA that's inside, the chromosomes that are inside that sperm. And so they might not.
Exactly.
You're more likely to be less than perfect or defective.
It's interesting because there is so much redundancy in sperm production. There's millions and millions of sperm that are produced, right? And for egg production, it needs to be a little bit more precise. But for sperm production, whoever created this process, it's kind of interesting that
Must have been
you
a
only
man.
need one.
Just kidding.
It must have been
I'm
a man. You really only need one normal sperm to do the job, right? Even though there's millions and millions. And so there's this natural redundancy because we know that there's, by far and away, most of them are going to be abnormal. The production is not perfect. And so to your point, Dr. Angel, yes, that if there is abnormal morphology, which is what we look for, is there a missing tail? Is it a pinhead? Is it this? Is it that? There's less of a chance that it's going to be able to penetrate the ovum that, and cause a fertile embryo, cause it to fertilize. So this is also why things like intrauterine insemination. And well, I should step back and say that's kind of nature's way of preventing some genetic abnormalities, that we only want the ones that are more normal actually doing the job. Because, if an abnormal one gets in there, well, then that might end up in an early miscarriage, or it might end up in, in other abnormalities if the baby comes to full term. So that's nature's way of kind of keeping things more precise, if you will. And then that is also why I feel like intrauterine insemination and IVF, although now IVF has gotten a lot better in terms of all they need is one normal sperm. They can test the sperm before putting it in. But in the old days, they would do IVF, and you're bypassing those natural barriers. And so there may be more abnormalities, especially with intrauterine insemination, where you're not really testing for one normal sperm. Whereas with IVF, you have normal sperm DNA.
Hey, thank you, Dr. Gabal and Dr. Angel. How about we move on to stuff you didn't know?
Yeah. I think a lot of people don't know that medications often start for one particular use and then end up being repurposed for something else. Dr. Gabal, do you want to tell us about the story of Viagra and how? Yes, and how
Ooh, and maybe even Propecia?
Yes. And actually there's 3 different meds that I can think of off the top of my head. I'm sure there's many more. So, first of all, I don't know if you're familiar with Latisse, which I use every day to help my eyelashes grow very long. It originally started as a glaucoma medication, where the patients were putting eye drops in their eyes, and they noticed they had these beautiful long lashes that they had to cut because they were like hitting their foreheads. And so, of course, Allergan being Allergan and brilliant, they took that medication and they remarketed it as Latisse for growing lashes. And then Propecia, as we had talked about earlier, was originally used as a prostate medication to shrink the prostate gland, but then also it was noticed that you could improve some male pattern baldness, and so it's now being used also for male pattern baldness. And then I think the most famous one is Viagra and how it was found, but that's because I'm a urologist and I was kind of there at the beginning of all those studies when they were doing testing for this new medication that they were trying to treat blood pressure and they were trying to treat like chest pain. And what happens with clinical trials, and I happen to have a lot more experience now with clinical trials, especially if you're doling out pills, the patients are supposed to bring the pills back at some point in order to count them to make sure they're taking them properly and they're not taking too many, and this and that. And so the patients weren't bringing their pills back. And
That is hilarious.
Because they were having this wonderful side effect that the Pfizer, then being Pfizer and brilliant, then marketed the medication. It turns out it didn't work that great for the original intent, but it worked so much better for the erectile dysfunction aspect. And so it's interesting how those things can happen.
I think the whole story of how Viagra came to be, and even the people that how nitric oxide, is it nitric oxide or nitrous oxide? Nitric oxide, right?
No, nitrous gets you high.
Yeah,
we do that at the office too.
Yeah, right. Okay. I mean, I don't know if you're familiar with this story, but how this all kind of was discovered in the TNT factories in Europe, and the people that were working in the factory were complaining of headaches a lot of the time, and the local cardiologists were starting to notice, the local doctors, that they didn't have the same rate of heart attacks as other nearby communities. And so that's how what is it? Trinitroglycerin was, which people put under the tongue when they're having chest pain. That's how that first came to be discovered. And it was then, periodically, like step by step after that, then we ended up coming to Viagra. I thought that,
That's
and I heard that story
fascinating.
actually from the guy who won the Nobel Prize for nitric oxide years later. So he's an Italian man. I can't remember his name. Should give him a shout out. But he actually told this story, and it was really funny because he said, and of course I was going to win the Nobel Prize because the Nobel Committee was made up of all older men. So they were really
Wow.
excited. Yeah, but so he was one of the people that discovered that the human body human cells can generate nitric oxide. So that's why
That's
he won
very
the Nobel Prize.
cool.
Fun facts. Another one stuff we didn't know. I did see one study, Dr. Gabal. I'm interested to see what your thoughts on it. It was not a huge study, and it was that people were self-reporting. There were about 650 men and presenting to fertility clinics, and they asked whether they used boxers versus briefs. And it turns out that the people wearing the boxers had higher sperm concentrations. And, logically it makes sense because the testicles like to hang low. They're slightly cooler. So people wearing the briefs might have warmer testicular temperature and might be not making as optimal amounts of sperm. I'd like to know your thoughts on that.
Yeah, and so that is definitely a thing that I think when we talk about infertility with our patients, we talk about different habits. And Raman, you were asking earlier too about jacuzzi and laptop use and that kind of stuff. So there are these studies that show that anything that warms the testicles too much is going to probably impede sperm production. And again, whoever designed us made it so that those organs lie really low and the temperature there is cooler than the rest of the body. And so anything that is going to warm them, bring them closer to the body, bring them closer to body temperature or even above, is going to it can affect fertility. But, when you look at a semen analysis, I know we have normal ranges, but there's many men who have abnormal semen analysis and are still dads. And so all we can say is like this, again, this is a spectrum, and that, the worse off this looks, probably the higher chance you'll have some infertility. But I can't tell 100% that a man with these abnormal sperm parameters, unless it's zero, that's the only one. If there's zero sperm, I can guarantee you can't impregnate someone. But even with low numbers, even with low motility, even with low morphology, normal morphology, there's still men who are running around out there who are impregnating lots of partners. And so, but it's all a spectrum.
Yeah, the fertility doctor did tell me, she was like, look, quitting vaping is going to do wonders for your sperm count and
Yes.
motility and morphology. But she's like, look, men and women have been having babies forever, and they're drinking and smoking and boozing. And of course, no one recommends any of that. And, if you want the best outcome that you can provide, do what you can, right?
Yes, absolutely, 100%.
Well, Dr. Gabal, we've learned so much, and I'm sure our
Yay,
audience
I
has
love that.
learned so much. This was so fun. I still kind of want to know like some weird, interesting patients. So we might have to have you on again so you can tell like fun stories from Dr. Gabal.
Yeah, I want to hear like the emergency stories of like penile and vaginal.
I
What's
could
going
tell you
on?
one right now.
Oh yeah, go for it. Let's end on a fun anecdote.
Yeah, when I was chief resident in urology, I'm on call. I'm in the operating room, and I get a call. This was would have been 2001. I got a call from the HIV clinic saying, we have a guy who's had a cock ring stuck for 3 days. I should say a penile occlusive ring. And so I was like, oh my God, I thought I was going to get to go home after this. And so I'm like, all right, send him to the ER. I'll meet him there. We'll figure it out. I'm probably going to have to come back to the OR. I'm thinking 3 days. What is happening down there? It's going to be a mess, right? 3 days. What takes someone so long to come to the emergency room after 3 days? So it was stuck. He couldn't get it off. I'm in the OR finishing a case, and I had my an anesthesiologist who said, next time tell him to use the Velcro ones. Those are much better. They're easier to get off. Because it turns out it was metal. It was a metal cock ring. And then I had a scrub tech who said, Dr. Gabal, go take these big bolt cutters down there. You could. And I'm like, dude, I'm going to scare the crap out of this poor kid. No, I'm not going to take the bolt cutters. So I go down and I'm like, examining him, and it really looked a lot better than I expected. I thought it would be swollen and black and blue, and it turns out I could get my finger wrapped around it. It was a very thick metal. I don't know what this thing was originally purposed for, but it was repurposed, and it was stuck behind his testicles. Okay.
It's like Propecia, repurposed.
Repurposed. And I could get my finger behind it, and I'm like, you know what? I'm going to save you and me a lot of time. I'm going to go grab these bolt cutters.
Oh my gosh.
And I'll be back. And so by this time, a bunch of other residents had heard, and the kid, he was so kind, and he didn't mind showing it to everyone. People were coming around and saying they were urologists, or maybe they weren't. And then they were like, this was back 2001. It was a long time ago, before HIPAA. And so then I came back with my bolt cutters, and he was holding his junk back, and I was like being really strong, and I felt like an orthopedic surgeon. I cut one part of it because these were big ortho like bolt cutters, and it still wouldn't give. It was so thick. So I had to turn it around. I had to cut the other half so we could split it. And he was so grateful. Thank you, doc. Thank you. Do you want to keep a half so you could show everyone? I just want to keep a half.
Oh my God. So is that something you learned in medical school? Like,
this is only by doing. This is why residency is so important. And so, yeah, we had a half of this cock ring hanging in the clinic for a long time while I was there.
And it wasn't even a cock ring. It was a makeshift.
Yeah, repurposed. Yeah. Next time, use the Velcro one. I did tell him that.
Yeah, that's great. Good advice for everyone.
I know, exactly.
Well, thank you so much, Dr. Gabal, for joining us today. This has been absolutely entertaining and educational, and I'm sure we're going to have a lot of listener questions, so we might have to have you back.
Thank you. I would love that. Thank you. Honored.
Nobody talks about penile health except for me and my sister all the time. And that's reason enough to love our podcast. Rate it wherever you listen, and please share it. This is something most people don't talk about, even with their doctors, let alone their siblings. But the data is real, the conditions are common, and the embarrassment is the only thing standing in between most people and actually getting help that improves the quality of their lives. And to my guy friends out there, and you know who you are, who all love having sex, send it.